So let us continue with the laboratory diagnosis. The type of specimen to be collected depends on the duration of illness. The preferred specimens to be collected are: in the first week of illness, blood culture, bone marrow, or the ordinal aspirate culture. In second and third week of illness, serum specimen for serology, example Vidal test. In third or fourth week of illness, urine and stool cultures. Okay. So in culture and identification, first of all, we do blood culture. Blood culture is the ideal method for diagnosis in the first week of fever, which becomes positive in about 90% of the cases. Thereafter, the positivity declines to 75% in the second week and 60% in the third week and 25% till the fever subsides. The specimen collection was discussed already in the previous chapter. In blood culture bottles, 8 to 10 ml of the blood may be collected in the blood culture bottle, either conventional bottle, brain heart infusion medium, monophasic or biphasic, or automated bottle like BACT or ALERT. Incubation: blood culture bottles are incubated at 37 degrees Celsius. Salmonella are non-fastidious. Growth occurs within 24 hours. From positively flagged blood culture broth, subcutaneous are made onto blood agar and McConkey agar. Subcultures are made on blood agar or McConkey agar. Colony appearance: blood agar, the colony appears non-hemolytic moist colonies. Okay. And in McConkey agar, the colonies are round, translucent, pale, and non-lactose fermenting. In stool and urine culture, it is useful for isolation of salmonella in the third and fourth week of illness. They remain positive even after antibiotic treatment. Stool and urine culture are also done for detection of the carriers. Okay, urine culture seldom becomes positive as salmonella are shed in urine infrequently. Urine is centrifuged and the deposit is inoculated on the McConkey agar. Stool culture is done similar to the method followed for Shigella. Appropriate media should be used to inhibit the common cells in the stool. Enrichment broth such as selenite F broth, tetrathionate broth, and gram-negative broth are used. Selective media such as low selective media such as McConkey agar. Highly selective media for the growth of S. typhi occurs as follows, like in DCA deoxycholate citrate agar produces non-lactose fermenting pale colonies with black centers. XLD agar, xylose lysine deoxycholate, produces red colonies with black center. Wilson-Blier's brilliant green bismuth sulfide medium is particularly useful for the isolation of S. typhi from heavily contaminated specimens. S. typhi produces characteristic jet black colored colonies with a metallic sheen due to the production of H2S. S. paratyphi A and others that do not form H2S produce green colored colonies. Okay. Now, the other specimens. Bone marrow culture is employed during the first week of illness, 55 to 90% sensitive when blood culture is negative, especially when patient is on antibiotics. The ordinal aspirate culture is recommended during the first week of illness if broth and bone marrow cultures are turned negative. Combination of blood, bone marrow and intestinal secretion culture is best method in the first week, which shows sensitivity of more than 90%. Other specimens from which salmonella can be isolated are rose spots, pus from suppurative lesions, cerebrospinal fluid CSF, sputum, and autopsy specimens such as gallbladder, liver, and spleen. In the figure, we can see colony of S. typhi. A shows the DCA deoxycholate citrate agar showing pale colonies with black center. B shows XLD agar xylose lysine deoxycholate showing red colonies with black center. Now coming to culture smear and motility testing. Gram stain smear made from colonies reveals gram-negative, non-sporing and non-capsulated bacilli. They are motile with peritrichous flagella. Identification of salmonella from the colonies is made either by automated identification systems such as Malditov or Vitek or by conventional biochemical tests as described below. It is catalase positive and oxidase negative, indole test negative, citrate test negative, urease test negative. TSI triple sugar iron test shows alkaline or acid gas present except for S. typhi, which is anaerogenic. Abundant H2S present except for S. paratyphi A. H2S is not produced. S. typhi speck of H2S present at the junction of slant and bat. Malditov can identify salmonella up to genus level. However, they poorly differentiate between serotypes as they share the same ribosomal proteins. Okay. Now comes the slight agglutination test. Identification of salmonella at genus level can be confirmed by slight agglutination using polyvalent O antisera. Then the serotypes can be identified by using type-specific O antisera. S. typhi agglutinates with O9 antisera. S. paratyphi A agglutinates with O2 antisera. S. paratyphi B agglutinates with O4 antisera. Fragile antigens can also be determined by using type-specific H antisera. Antimicrobial susceptibility testing AST is performed by disk diffusion method or Muller Hinton agar or by automated MIC detection method by microbot dilution, example by Vitek. Okay, so now let's start with demonstration of serum antibodies by Vidal test. Vidal test is indicated in 2 to 3 weeks of illness. It is a tube agglutination test that detects antibodies in the patient's serum against antigens of Salmonella typhi and S. paratyphi. Vidal test is one of the oldest and most widely used serological tests for diagnosis of enteric fever. It was discovered by Fernand Vidal in 1896. The principle it is an agglutination test where HNO antibodies against S. typhi and S. paratyphi A and B are detected and measured in the patient's sera by using O and H antigens. The antigens used are O antigen of S. typhi TO, H antigen of S. typhi TH, H antigen of S. paratyphi A AH, H antigen of S. paratyphi B BH. Note the paratyphoid O antigen cross-react with the typhoid O antigen due to their sharing of factor 12, hence they are not used in the test. The procedure: patient serum is serially diluted in normal saline in test tubes from 1 to 10 in 1 to 1 in 640 dilutions. 4 such tests are made. To each set of diluted sera, respective 4 antigen suspension TO, TH, AH and BH are added. Test tubes are incubated in water bath at 37 degrees Celsius overnight. Okay, now the result is read using a concave mirror. If corresponding antibodies are present, then agglutination reaction will occur, leading to mat formation, and the absence of the antibodies would lead to pattern formation. Okay, so O agglutination appears as compact granular chalky clumps, disc-like pattern with clear supernatant fluid. Okay. Now H antigen appears as large, loose, fluffy cotton woolly clumps with clear supernatant fluid. If agglutination does not occur, pattern formation occurs due to the deposition of antigens and the supernatant fluid remains hazy. The tighter the highest dilution of sera at which agglutination occurs is taken as the antibody titer. For interpretation, the results are interpreted as the S type infection antibodies TO and TH antigens are raised. In S. paratyphi A infection, antibodies to TO and AH antigens are raised. In S. paratyphi B infection, antibodies to TO and PH antigen are raised, as we will see in the table. The significant titer says that any titer is not significant in endemic countries like India due to prior exposure. People will always have some baseline antibodies. Then also H antibody titer of more than 1 is to 200 is considered significant, whereas significant titer of O antibody is taken as more than 1 is to 100. Lower titers may be produced in cross-reacting infection and therefore should be ignored. Okay. The cutoff varies from place to place depending on the endemicity of the disease. In the figure, we can see O and H agglutination in Vidal test. The reading is taken in a mirror. Now the interpretation of Vidal test result, and what does it suggest? Rise of TO and TH antibody, enteric fever due to S. typhi. Rise of TO and TH and AH antibody, enteric fever due to S. paratyphi A. Rise of TO and BH antibody, enteric fever due to S. paratyphi B. Rise of only TO antibody, recent infection due to S. typhi or S. paratyphi A or B. Rise of only TH antibody, convalescent stage or anamnestic response. Rise of all TH, AH and BH antibodies post-TAP vaccination. So in this figure we can see this is the dilution was to 20, 40, 86, 160, 320, 640 and the saline control is there. The Vidal test here shows the titer of 1 is to 160 and TO 1 is to 160 and TH 1 is to 320. Now, significant titer in most places in India are taken as we have already discussed. H agglutination more than 200 and O more than 100. Low titers should be ignored and considered as baseline for endemic areas. Now, false positive result can be there due to anamnestic response. It refers to the transient rise of titer due to unrelated infections like malaria, dengue in persons who have had prior enteric fever. If bacterial antigen suspensions are not free from fimbriae, person with inapparent infection or person with prior immunization with TAP vaccine. Okay. The fourfold rise in antibody titer demonstrated by testing paired sera at 1 week interval is more meaningful than a single high titer. Rising titers is in anamnestic responses are transient that usually falls after 1 week, whereas in true infection the titer increases by fourfold after 1 week. False negative. Viral test may occur in early stage first week of illness, late stage after fourth week, carriers, patient on antibiotics, and due to prozone phenomena antibody access. This can be obviated by serial dilution of the serum. Okay. So this is it. O agglutinins can appear early and disappear early and indicate recent infection. H agglutinins appear late and disappear late. O antibodies are serotype non-specific. They are raised in all infections, that is S typhi, S paratyphi, A and B. H antibodies are specific. TH, AH and BH antibodies are raised in S typhi, S paratyphi, A and B infections respectively. So there are some other antibody detection tests as well. Various commercial methods are available like typhi dot test, 50 kilodalton or OMP, outer membrane protein antigen is used. It uses a dot ELISA format to detect both IgM and IgG separately after 2 to 3 days of infection. Okay. IDL tubex test, O9 antigen is used. It detects only IgM antibodies against S typhi by a semi-quantitative colorimetric method. IgM dipstick test and ELISA detect anti-LPS IgM antibodies. And molecular dot blot assay flagellar antigen is used, detects only IgG antibodies. And molecular methods can be used. Uh, Several polymerase chain reactions can be used. Okay. Demonstration of serum antigen. Antigen on the typhoidal salmonella are consistently present in the blood in the early course of the disease and also in the urine of patient during the late phase. Several methods such as ELISA are available for antigen detection. The molecular methods now. Several polymerase chain reaction PCR based methods are available to example nested PCR are available to detect and differentiate typhoidal salmonella by targeting various genes such as flagellin gene, IROB and FLIC gene. Okay. The other non-specific findings, WBC count neutropenia seen in 15 to 25% of the cases. Leukocytosis is the most common among children during the early phase and in some cases complicated by intestinal perforation or secondary infection. Liver function test moderately dearranged and muscle enzyme levels are moderately elevated. Next is the antimicrobial susceptibility testing. It can be performed by disk diffusion method on Muller-Hinton agar or MIC based method, example White. The detection of carriers. Culture by stool and bile culture detects fecal carriers and urine culture detects urinary carriers. Detection of VI antibodies is done by tube agglutination test by using S typhi suspension carrying VI antigen Bhatnagar strains. Even a titer of 1:10 is also considered as significant. However, the diagnosis should always be confirmed by the culture. Isolation of salmonella from sewage. It is carried out to trace the carriers in communities. It can be done by sewer swab culture. Gauze pads left in sewers are cultured on highly selective media such as Wilson and Blair media. Filtration. Sewage can be filtered through millipore membranes and then the membranes are cultured on highly selective media. For the treatment, prompt administration of appropriate antibiotics prevents the severe complication and reduces the mortality to less than 1%. Treatment of the case depends on the susceptibility of the strains. Current recommended regime are as follows. Third generation cephalosporin, ceftriaxone is the drug of choice for empirical treatment given 1 to 2 gram per day IV for 10 to 14 days. Azithromycin is the alternative drug for empirical therapy. Advantage is it is given orally 1 gram per day for 5 days. Fluoroquinolones, example ciprofloxacin, because of increased drug resistance, it should not be given empirically. It can be given orally if found susceptible. It is given as 500 mg twice a day, oral for 5 days. Now, drugs that were used in the past were chloramphenicol, amoxicillin, and cotrimoxazole. These drugs were stopped from usage because of emergence of resistance. Treatment of carriers include ampicillin or amoxicillin plus probenecid given for 6 weeks. Now, very important topic which is drug resistance in typhoidal salmonella. Antimicrobial resistance in typhoidal salmonella is a global problem. Multi-drug resistance S. typhi is defined as resistant to chloramphenicol, ampicillin and cotrimoxazole. These antibiotics were used to treat enteric fever in the past. MDR strains emerged in 1989 in China and Southeast Asia, including India, and since then they have disseminated widely. Fluoroquinolone FQ resistance. After the emergence of MDR strain, ciprofloxacin became the drug of choice in the year 1990 and was extensively used for 3 decades. This led to emergence of drug resistance to FQs, mainly seen in India and other regions of Southern Asia. In India, the ciprofloxacin resistance to salmonella is very high, more than 70% in 2019. Okay, the key mechanism responsible for FQ resistance mutation in GRA and PAR-C genes. Resistance to ceftriaxone, it's a very rare, less than 1%, has been reported recently. Both extended spectrum beta lactamase ESBLs and AMP-C beta lactamase producing S typhi have been detected. Old is gold. Interestingly, it is noticed that many strains reverted susceptible to olden days drugs, amoxicillin, chlorphenicol, cotrimazole, as they were not in use for a long time. Prophylaxis. Theoretically, it is possible to control or eliminate enteric fever since the agents survive only in the human host and are spread by contaminated food and water. More developed countries have proven this. However, in developing countries, this goal is currently unrealistic due to the lack of adequate sewage disposal and water treatment. There are three lines of prophylactic measures: control of reservoir, sanitation measures, and vaccine. Control of reservoir. Control of the cases by early diagnosis and prompt effective treatment. Disinfection of the stool or urine soil clothes with 5% cresol, 2% chlorine, or by steam sterilizer. Follow-up examination of the stool and urine culture to detect carriers twice at 3 to 4 months and at 12 months. Control of carriers. Early detection of carriers by stool or urine culture by detection of VI antibodies. Effective treatment of carriers by ampicillin or amoxicillin 4 to 6 gram per day plus probenecid 2 gram per day for 6 weeks. These drugs get concentrated in bile and may eliminate 70% of the carrier state. Surgery. The cholecystectomy plus ampicillin is regarded as the most effective approach for carrier state and elimination, 80% cure rate. Okay. Now, starting with sanitation measures. Sanitation measures include the following: protection and purification of drinking water supplies, hand washing and improvement of basic sanitation, promotion of food hygiene, health education. For vaccine, immunization provides short-term protection. It is indicated in the following situation, like travelers going to endemic areas, people attending melas and yatras, household contacts, people at the increased risk, example school children, people living in endemic area, which is optional. There are three types of vaccine available for typhoid fever. First, VI antigen capsular polysaccharide vaccine, VICPS. Okay, it is composed of purified VI capsular polysaccharide antigen derived from S. typhi strain TY2. Dosage: single dose containing 25 microgram of VI antigen is given IM or subcutaneously. Vaccine confers protection for 2 years. Booster is given every 2 years. Age: it is given only after 2 years of age. Capsular antigen, being T-independent antigen, is poorly immunogenic to children less than 2 years. VIREPA. VI antigen is conjugated with recombinant Pseudomonas aeruginosa and exotoxin A. Conjugation increases immunogenicity of the VI antigen. Therefore, this vaccine can be given to children less than 2 years. Okay. Now comes the Typhoral oral live attenuated S. typhi TY21A vaccine. Typhoral is a stable live attenuated mutant of S. typhi strain TY21A, which lacks the enzyme UDP galactose 4 epimerase GAL-E mutant. On ingestion, it multiplies for some time, initiates the immune response but self-destructs, dies of its own after 4 to 5 cell division due to lack of GAL-E enzyme, and therefore cannot induce any pathogenesis. It is indicated only after 6 years of age. The vaccine is available in lyophilized form as enteric coated capsules. It is given orally before food on alternate days 1, 3, 5, 7. No antibiotics should be given during this period. The vaccination is recommended every 5 years with a full 4-dose series. Protective immunity starts after 7 days of the last dose and lasts for 4 years. Parenteral tab vaccine is a heat-killed whole cell S. typhi paratyphi A and B vaccine. It is no longer in use because of significant side effects. So, last topic of the chapter is non-typhoidal salmonella. Non-typhoidal salmonella cause mainly gastrointestinal manifestation and have been described later. However, up to 8% of patients with NTS gastroenteritis develop into bacteremia, which can lead to either to endovascular infection or seedling to various organs, leading to metastatic infections. Risk factor for bacteremia include NTS serotype, most common being the S. cholerasis, source pig, and S. dublin, source cattle. Age: infants and elderly people are at higher risk. Immunity: HIV and other conditions with low immunity. People with pre-existing valvular heart disease. NTS can cause endovascular infections such as endocarditis and arthritis. So this completes the chapter. Let us discuss the expected question. First question: Meena, a young adult female, was admitted to the hospital with intense headache, abdominal discomfort for past 5 days. She had also developed fever, which is of remittent type with gradual rise in a stepladder fashion. On examination, she was toxic with temperature 101 degree Fahrenheit. Tongue was coated and mild splenomegaly was present. So we can diagnose that this is a case of enteric fever. And we can describe the pathogenesis, methods of sample collection, lab diagnosis, and treatment and vaccination as well. Short notes on typhoidal carriers and drug resistance or salmonella have been already discussed. Coming on to MCQs, S. typhi is the causative agent of typhoid fever. The infective dose is B. 10 to the power 3 to 10 to the power 6 bacilli. In patients with typhoid diagnosis after 15 days, the onset of fever is best done by D. Vidal test. Antibodies against which of the following antigen appear early in the following infection with S. typhi? B. O antigen. In Vidal test, rise of TO and AH indicates infection with B. S. paratyphi A. Question number 5. Antibodies against which of the following antigen appear in typhoid carrier? A. VI antigen. Bacteria mediated endocytosis BME is observed in which organism? 6. C. Salmonella. And 7th question: currently the drug of choice for enteric fever is ceftriaxone. Okay, so this completes our chapter enteric fever. We'll be starting with the next chapter in the next video. Okay, thanks for watching. Like, share, subscribe.